Hello?
Hi.
Hello, can you hear me?
Yes, I can hear you, Crystal. Hi.
Hi.
I'm glad. Are you able to get yourself in and out of mute?
Uh, I'm gonna try it. Just give me 1 second.
I'm here as well, Julia Davis.
Hi, Julia. Yes, I'm seeing you now. I just want to make sure you're also able to get yourself in and out of mute. I know there was some trouble with that last time.
Okay, I'm gonna try it now. So I'm gonna put myself on mute for a second.
Yeah, no worries.
Okay, can you hear me now?
Yes, I can hear you now.
Okay, all right. So looks like well, my mute is working.
Okay, great.
Yeah, I think mine is too.
Perfect. I'm gonna start to share my screen and hopefully everything can work out just fine. Is everyone able to see the PowerPoint presentation?
Yes.
Yes.
Um, where did that go? Oh, okay, let me see if I can. Hi, Latrice. Hi, Samia. Can you all hear me?
Yeah.
Let's start to see if I can put my camera on. Okay. Working.
You know what? I can't find my camera.
Yeah, me either.
Okay, it's not just me. All right, I thought I was having a moment.
No, I was just gonna say the same thing.
Were you all able to use the panelist
It
password
didn't
or
really
was
give me an option. I just clicked on it and I had it ready to
Yeah,
the
same here.
password ready, but it never gave me that
Same,
option.
oh
same here.
you had no problem signing in. Okay, then maybe that's why there's no camera availability. And that probably will be the same for some of our other guests. So it's okay, we can just go off like that. And I just want to make
Okay.
sure all the other features are working as we wait for people to start coming in. Hello, everyone. Welcome. We're going to give everyone a couple minutes to sign in. Hello, everyone. Welcome. We're just gonna give everyone two more minutes to log in. I know there sometimes is some delays or passwords, registration links, so just gonna wait a couple minutes and then we'll get started. Welcome, everyone. Just waiting one more minute before we get started. Welcome, everyone. We're about to get started with our presentation. If someone can give me like a thumbs up or a reaction that they can see the PowerPoint slide. Okay. I think we are good to go. So welcome everyone to our April Heart Disease and Stroke Prevention and Innovation Collaborative. It's good to connect everyone again, as we usually do on this monthly basis. For today, as always at the top, we will talk through some program updates, things that we have, coming forward in the next couple of months for this learning collaborative. Quickly, we will also have this open discussion about data products. Shannon will be leading that, and we'll have some polling going on through something should pop up that will allow you all to either multiple choice question submit or open survey submit. And we'll also like for you to get off mute if possible. I believe I've given everyone the opportunity to get off mute, just so we can have a quick open discussion about some data products. And then we will follow that up with 2 grantee report outs by La Clínica del Pueblo and Elaine Ellis Health Center. And then we'll wrap up with some Q&A and next steps. I don't believe anyone has the ability to come off video. I think that's a WebEx situation, but please introduce yourself in the chat, name, title, organization, or affiliation. And for today's icebreaker, if you can let me know, if spring had a soundtrack, what song would it be? So I think the weather is really nice. Things are starting to bloom. So we want to hear from you. If spring had a soundtrack, what would it be? So if you can all just write that in the chat, we greatly appreciate it. So like we said, today's learning collaborative theme will be surrounding our grantee report outs. Those are the work plan and goal or objective related report outs from our health system partners. And our May Learning Collaborative will have in-service presentation, one with WellCentric DC, who will give us a presentation on the services that they provide and how to refer to their services. And we're also working on another in-service presentation to be determined. Following the May Learning Collaborative for June, we'll have another round of work plan report outs, grantee report out sessions, and those are to be scheduled as well. And sometime in the summer, we'll have we'll make sure to follow up with everyone and inform everyone of our July and August themes. Now I'm going to pass it on to Shannon, who will start up this products open discussion.
And we can't hear you if you're speaking.
We can't hear you, Shannon or Bonnie.
No.
Oh, there you
Oh.
go, Shannon.
Sorry about that. Can everyone hear me now?
Yes, I can hear you now.
I'm still not able to hear Shannon. Is anyone hearing Shannon?
I still can't hear Shannon either.
No.
Oh,
Who's there?
Is that you, Shannon?
You hear me now?
Yes, we can hear you now.
Oh my goodness. It's like toggling between four mics. Okay. Good afternoon, everyone. I'll try to make this brief. So the Chronic Disease Division we're really committed to designing products and solutions that meet the needs of our partners. And so we've currently created several data products that are designed and created from the data that we receive from our partners, data that we receive from Burfus, from other data sources within the agency, and just want to ensure that what we're creating has utility for you, that you find it useful. And if there are other products that you'd like to see, we want to be aware of that so we can develop them. So just quickly, these are some of the things that we're already doing. So we have, at least for the past year, implemented the framing and data component of our learning collaboratives, and that's really where Samia leverages data to ground the conversation or root the conversation. We have community presentations that we deliver, whether it's with national organizations like the American Diabetes Association or local churches, really the full range. We have our behavioral risk factor surveillance fact sheets. So these used to be published externally. We now have them available internally and use them for presentations, but can be available on request. We have the what to know fact sheets. So these are condition specific and designed for the layperson. It's really intended to be resident facing. These are tools that are available, or documents that are available on the DC Health website. We can also send them to you if you want to print and have in your waiting rooms or community events. We have the grantee snapshot reports. So these are grantee specific and are sourced from our internal dashboard. And we share them with you quarterly. We also, within the division, have performance oversight. So this is where we report some of our high-level metrics to DC Council, and that's really in an accountability space. And then we have our chronic disease dashboard, which is internal. Upcoming, we're in the process of developing through lines reports. So these are data reports with more narrative context. And then we will have a chronic report board that's also public facing, where we will track multiple levels of the chronic disease life cycle, from behavioral risk factors to metabolic risk factors to chronic disease and mortality. So that's in the pipeline. Next slide. Okay, so we just have 2 questions for you. The first is, which DC Health data products do you currently use to support program decisions? So here are some, and you can include these or list another. These are the framing the topic and data modules, the what to know fact sheets, the BRFIS dashboard, or the grantee snapshot reports. And if there's another product that's not listed here, you can add that.
So a Slido question should have popped up for everyone. We are also open, please get off mute if you have any questions or you have any comments, or if you responded other, we'd love to hear what those data products are like for you.
We are looking for 100% participation here to help us ensure that that we're designing what you need. So, Bonnie, when I select this, it's only allowing me to select one at a time.
Oh, so the first question and the second question
It says select all that apply, but you can only select one.
You're on mute, Bonnie.
Oh, so sorry about that. I
Mhm.
don't know why that did not let me pick more than one.
I guess folks can pick one and then put the others in the box, maybe.
Yeah, that'd be a good way to do it.
Okay.
Or in the chat as well, we'll collect frequency in the chat box.
Disappeared for me.
Yes. That hands open. Oh, it's
Okay.
up.
Okay. All right. And for the next question, are there any other data products that you currently use to support program decisions? So these could be dashboards, maps, briefs, infographics, slide decks. And if so, please name the product and the source. Also, if you've come across, I can't share my screen, but I know there are products from other states that are that you may have come across that might be helpful for us to have here in DC. Please feel free to put those in as well. Here we go. Share.
Does anyone have any questions?
So these are New York City has epi data briefs, for example. Yeah, if there are any any products that you've come across that you think might be helpful for us to create here. Can't see how many folks have participated. Bonnie, can you see? Oh, you're on mute.
Yes, I can see. I think we still need a couple more for the open text. If anyone just maybe can throw some ideas out there, or if they want to just talk through that with us, if you can get off mute if possible, that would be great as well. And maybe we can also follow up after this call with an email and give you all more time. Okay. Thank you so much, Shannon. We're just
Thank
going to
you.
keep moving on just to give everyone enough time. I invite Julia Davis from La Clínica del Pueblo. Julia, please let me know if you're able to hop off mute.
Hi, yes. Can you hear me?
Yes, we can hear you.
Okay, awesome. Okay, so hi, I'm Julia. I'm the clinical nurse manager at La Clínica del Pueblo for both of our clinical sites in DC and Hyattsville. And I'm just going to be talking about our new nursing hypertension protocol that we just implemented last month here at La Clínica. It's basically just a standardization of the excellent hypertension care that was already happening. So the objective of the protocol is in line with one of the objectives for our Million Hearts grant, and it's the expansion of nurse-led hypertension management services via a standardized evidence-based nursing intervention protocol. Next slide. So there's tons and tons of data that supports nursing in hypertension management. Nurses play a really important role in helping patients manage their blood pressure. And the main point here is that it has to be like a long-term process, like multiple touch points with patients leads to better outcomes, helping them to adopt healthier lifestyles and improve adherence. Okay, so I'm going to jump into the protocol. So basically, this is a very watered down slide telling you what we're doing. So the provider is going to refer a patient to nursing if they have elevated blood pressure or a hypertension diagnosis. And then the nurse is going to complete an assessment to determine the most appropriate evidence-based interventions to support the patient's hypertension management. And then we'll provide ongoing structured care until the patient's goals are met. And a really important piece of this is that all decisions and goal setting are made in partnership between the nurse, patient, and provider. So this is a list of the evidence-based interventions. I'm not going to go into great detail with any of them, but the main idea is to offer the nurses received training in each of these interventions. And basically every time they see a patient who has elevated blood pressure, they're going to be assessing and then picking from this list of interventions to decide, like based on their assessment, what is the best plan for the patient. So I'll just go through these really quick. We want to make sure that we're accurately measuring their blood pressure. We need to be doing 2 checks at every visit and ensure that the patient is properly positioned and that we're using the right equipment. So everybody got trained, did a competency in that. The structured follow-up, again, is a huge piece. We're going to be making sure that we are seeing the patient either in person or over the phone every 1 to 4 weeks. Self-monitored blood pressure, support. So we want to make sure every patient has a monitor, knows how to use it, and is logging their numbers. Med adherence. So we are meeting with our patients to assess barriers to adherence, see if they're having any side effects, and making sure they understand what meds they're taking and why. And then the big one, lifestyle management. We are providing education on diet, exercise, stress management, and substance use. So any patient who has uncontrolled blood pressure or a new hypertension diagnosis is eligible to be referred to nursing. The patients that are currently enrolled are all have uncontrolled blood pressure. Their average age is around 60 years old, and the vast majority identify as members of the Latin American community. And then the team members involved is, of course, the nursing team, medical providers, the community health action or health educators, and other places they call community health workers, and then the health informatics team for tracking. So this is how we're referring to nursing. We're requesting an appointment with, so the patient is here seeing the provider, and they're going to request a follow-up with nursing at checkout. Currently, we're using TEs for referrals, which isn't ideal. I'm hoping to implement an internal referral process soon because it's much cleaner and easier to track. But for now, we're using TEs, and we're asking the providers to indicate the patient's goal, blood pressure, and then any instructions that deviate from the standard of care, which I'll get to in a few slides. And then everybody coming to nursing ideally will have either a prescription for a blood pressure cuff through their insurance, or the list of validated cuffs. So because we work with a lot of uninsured folks, they can't always get their cuff through the insurance company. So we have put together a list of blood pressure cuffs that are for sale from Amazon, Target, and Walmart for like around $30, and they're all validated cuffs because we want to make sure that they're using machines that actually work. So we want them to have one of those two things, and then a standardized blood pressure log, which I have an example of in a second. So this is just for the nurses before the visit. We want to make sure that they go through the med list, check the patient's insurance status, because this will affect the interventions, like how we will carry out the interventions, read the most recent provider visit note, and then review the referral from the provider. So this is our intake visit. It's always going to be in person, and it's a lot of stuff to go over, but the nurses do it. And the goals of our visits is to get to know the patient, figure out their education level, literacy level, preferred learning styles. We're going to assess their readiness for change and motivation for change. How interested are they in improving their blood pressure? We're going to assess their understanding of hypertension and give an introductory education as needed. We're going to get a baseline of their blood pressure and vital signs, as always. We're going to verify that they have the monitor, because even though we're requesting that they come with the monitor, obviously sometimes things happen. So we're going to make sure that they have one. And if they don't, why, and what can we do to get them one? And then make sure they know how to use it, make sure it fits on their arm. We're going to do a medication review with adherence assessment and make sure that they have access to all their meds, again, with patients without insurance or with all the complications of insurance going on. Educating.
Oh, sorry about that, Julia. Can you just retract what you said in the last couple of seconds? I think we lost audio there.
Sure. Okay, I'll just go back a couple bullets. So we're going to assess diet and lifestyle, and we're going to set goals for care, and then we're always going to assess for signs and symptoms of hypertension like urgent symptoms and make sure the patient's aware of what those are so that they can take steps at home if necessary. Next slide. Oops, sorry. Okay, so then these are our follow-up visits. They're going to be similar to the intake, just with less, we're just following up on everything we did in the first visit. So these can be in-person or telehealth, depending on the nurse and patient's decisions. So we're always getting 2 BP readings at every visit, 1 to 2 minutes apart. We're gonna, again, assess med adherence and provide education as needed, assess the signs and symptoms of hypertensive emergency. So have you had any of these symptoms since our last visit? And if you did, what did you do about it? Making sure that they know how to handle that kind of thing. Assess diet and lifestyle and provide education. And then the big thing here is reviewing their home log. So again, making sure that they are checking their blood pressure at home, know how to do it, and seeing what their home readings are, and then getting an average. And then goal review and encouraging them to keep up their provider visits. So this is a, sorry, you can go back. This is the blood pressure log that we created. The nurses and providers, and I understand where they're coming from, say that patients don't want to check their blood pressure this much, but this is what the AHA says we should be doing, checking twice in the morning and twice in the evening. So that is the standard that we're recommending. And again, if the patient says they don't want to do that, then we're just going to kind of work with them to see what they are willing to do. So frequency of visits, as I mentioned at the beginning, ongoing structured follow-up is key here. So we're going to recommend a certain frequency of visits depending on the patient's risk level, how out of control is their blood pressure. But again, it's based on the patient and nurse's decision. So, I might want the patient to come in every week, but they don't want to come every week. So they're going to come every 2 weeks. We're going to compromise because we want to be partners in their care and get them to come in as often as they're willing to. So documentation, I'm currently working with Health Efficient to make some templates for these visit notes so that we can track a little bit at a more granular level how the interventions are affecting outcomes. And I'm also working on figuring out how I can input home readings to be seen in like a flow sheet instead of just having to free text numbers, because that isn't super helpful to anybody. But this is kind of in progress. Next slide. Finally, patients will remain in nursing care, ideally until they reach their blood pressure goal. Again, sometimes patients don't want to keep coming to see us, but if they're willing to keep coming, we're going to keep seeing them until their pressure is under control. And we're considering their goal being met with 2 consecutive visits of average home readings and in-clinic readings at goal. So we want to just make sure that they're consistently at goal. This is for the providers, but again, just making sure that we are trying to get everybody a blood pressure monitor. So in my experience, we didn't always send someone home with a blood pressure monitor. It was kind of more just for our folks who are super uncontrolled, but AHA says that everybody with a hypertension diagnosis should have a monitor. So again, we're going to try to get it through the insurance if possible. And if not, we have the validated BP cuff list, and my CHO, Dr. Amina, and I are working with AHA to see if we can source some free cuffs for our uninsured folks, but that's in the works right now. So this is just like the standard of care. So when the providers are sending us referrals, we're asking them to indicate the goal blood pressure, and then if they want the patient checking their pressure differently from this twice in the morning, twice in the evening, they need to indicate that. And then the AHA recommendation for exercise is written right here. So if the provider wants the patient doing something different than that, they need to indicate it in their referral. This is, again, just for the providers to make it as easy as possible for them to fill this out and give us the information we need. I created a dot phrase in ECW so they can just input the information and send it to us. And then these are just some resources that we created for patients, nurses and patients and providers. So we have the logs that I showed you in English and Spanish. We have our validated BP cuff list in English and Spanish. And then I'm working with our communications and health education teams to create some La Clinica specific diet and exercise handouts. And then we have an AHA handout on how to check your blood pressure. So we printed copies of these, and they're like in a easy to find place in the clinic. And then I also share digital copies with everybody. So my next steps are refining our ECW templates to improve our ability to track. Like, I want to be able to see which specific interventions are, like how specific interventions are affecting patient outcomes. So I'm working on creating templates for that and to just standardize documentation. I'm working on reinforcing the referrals process with the medical providers, improving access to BP monitors. And then quick note, the CHA is our community health action. So we have health educators here at La Clinica. They're really amazing, and they provide a lot of really great education on diet and lifestyle. And so working on standardizing the referral process between nursing and CHA and making sure that our education that we're providing on both teams is like complementary and unified.
Yeah. Thank you so much, Julia. I think it was great information for us to have and follow. Does anyone have any questions? You feel free to put it in the chat box or come off mute. Did you have any questions for the Learning Collaborative, Julia, that, to kick us off here?
The only thing I was thinking about in preparing for this was if anybody that uses ECW, like templates for hypertension care for nursing. I know they exist. I just haven't found any yet.
I know we have some, like an ECW optimization toolkits that we've shared, and I'm sure that there's some types of templates out there that could be used to model or to transition to see how that can be utilized. But I'm sure we can talk further that together as needed. Shannon had a question in the chat box. Any measurable early findings that you can share?
That's a great question. So I don't have like data, but I have heard from the providers and nurses that they're seeing like drastic improvement in patients' blood pressures. So I think historically we weren't doing the structured follow-up. It was kind of a patient comes in, they have a high blood pressure, then they'll come see nursing, and then we didn't really follow them. And now that we're doing regular structured check-ins, the providers and nurses have shared that they're seeing like significant improvement in patients' blood pressures.
That's great information to have. All right. Well, thank you so much, Julia. We are going to move on to our next report out. If anyone has any questions that they think about later on, please put that in the chat. And we will share that information at the end also if you need to connect. our next report I will be from Elaine Ellis, Health Center. Crystal, please confirm you can get off mute and we'll start the presentation.
Okay. Can everyone hear me?
Yes.
Yes.
Okay. Awesome. Awesome. Good afternoon, everyone. My name is Crystal Green. I am the Health Risk and Quality Coordinator here at Elaine Ellis Center of Health. My presentation today will be covering a couple of objectives that we have on our work plan, but the overall goal is basically looking to improve standardization of best practices of health outcomes, looking to improve blood pressure and diabetes numbers. The target population that we basically focused on for this project year is for our community event outreach patients and African American male patients. Next slide, please. So here at Elaine Ellis, we are a small FQHC that's located, had two locations. We have a location in Washington, D.C. in Ward 7, and we have another location that's about 10 minutes away located in College Park. Basically here, since we are a small center, we have a big heart and a big mission to serve. One of the things that we do here, in addition to serving our regular patients, we provide a number of and participate in a number of community outreach events. With these events, we basically look to do cardiovascular screenings with blood pressures and HbA1c screenings. When this started originally, a couple of years ago, we did a couple of events here and there, and we also here at Elaine Ellis sponsor two big major events during the year. We do a big back to school giveaway where we give back to school supplies and everything for the community, and we also do a turkey giveaway. We give away turkeys, and we also do, health screenings for those events. When I first started a couple of years ago, these were big events, and then we may have participated in another little smaller events. Over the course of the last couple of years, our participation in events have grown considerably with our community partners. We now work with a number of community partners. We also include some of the schools or the adults in the schools through PG County's school departments as well. So we are doing a large number of community events. We could average anywhere near between 3 to 4 events a month, depending on the month and everything. So by us providing community outreach patients, we're getting a large number of participants there. But what happens once you service these patients and everything? Does it just, stay in what we call cyberspace in our EMR? No. In a nutshell, they actually still become your patients, because for a lot of these patients, they become our main point of care and probably their first exposure to healthcare in reference to screening for high blood pressure and diabetes. So Elaine Ellis basically continues to improve. Can you go back to the last slide, please? Thank you. Basically, we're looking to improve the workflows by implementation best practices for clinical care. We always looking to improve workflows in reference to controlling high blood pressure and diabetes screening. We have a robust collaborative relationship, as I mentioned before, with a number of community organizations. We sponsor and participate at these events, and we always do cardiovascular screenings at these events. Historically, with these event participations, especially in reference to blood pressure and HbA1cs, historically, we might have only converted maybe about 5 to 7% of these patients looking to establish care with us here. So the goal for our program, since we were looking to revamp and revitalize our community outreach initiative this year, we want to raise that goal to at least 15% conversion of those community outreach patients. Next slide, please. So we have a team here at Elaine Ellis that basically does the community outreach. And that team basically consists of the front desk, a medical assistant, a community health worker, the provider that's providing the clinical care, and someone in admin leadership. Next slide, please. In addition to those individuals, depending on how large the scale of the event is, we also consist of a transportation coordinator because we also have a mobile unit. Or if we just have a lot of activity a lot of equipment to bring and stuff like that, we need a coordinator to basically coordinate to make sure that we have enough room and enough equipment for these. Some of these events, in addition to cardiovascular screening, we also have dental support, basically to help us out for, dental screenings and everything. We also have additional admin support as assigned. And then, of course, when we have our two largest events during the year that I mentioned prior, everybody, all hands on deck, including myself. The stakeholders for these events is basically, of course, Elaine Ellis's QA improvement team, the organizational leadership, and of course, DC Health. The way the activities really roll as far as how a community event works is, since we have an ongoing partnership with a number of organizations, we basically set up and confirm that we're going to participate at a community outreach event. We basically do the screenings, which is blood pressure and now A1Cs screenings. If the patient is normal and everything, we still give the opportunity for the patient if they want to establish care with us, if they do not have care. If they don't, we still provide ongoing counseling and patient education for them to keep, doing what they're doing and answer any questions they may have in reference to those conditions. If the patient does have an elevated or uncontrolled or abnormal screening, if they want additional care and additional treatment, we can actually refer them back to one of our center locations. They can get a same-day appointment and they can have more treatment, counseling, or whatever. And they can look to establish care if they want, in reference to, making sure that they get their numbers in control. After each event, basically, we call it a hot wash. We basically relook at how many patients we served, how many patients we may look to reach out to that may need care, or we may look to go ahead and just reach out to all of those individuals that participated and just ask them if they want to establish care or if they have any questions or would like to come in for additional care. Next slide, please. So for our community outreach events, you basically have, successes and challenges in reference to when you establish something like that. Successes. During this project year, we have served over 284 patients providing high blood pressure screenings, HbA1c education, and counseling. Out of that number, 45 patients were diagnosed with uncontrolled blood pressures at these screenings. 10% of those patients have already gained, but we gained from these events have already looked to establish care and already taken a proactive approach. That means a lot of them were like just normal readings and they still wanted to still come and seek us out for us to be basically their medical home. In addition to another success, we're basically looking to expand again our relationship with our community partners, which means we're getting more and more requests for us to come and do more of these screenings with our community partners. In addition to this, we've also expanded our workflow to start including SDAOH screenings in reference to these patients to make sure if they have any barriers and to see if we can look to eliminate these barriers. In addition to these successes, we do run into some challenges. At first, when we were doing this program year, we weren't really screening that much for HbA1cs. Earlier in the project, we ran into logistical issues, which could range from we didn't have enough equipment or we didn't have a good area to really set up and do these screenings and everything. It just depended on the event. We just had to basically reprogram ourselves to make sure that we could do this event at these events, and then we just had to pick and choose, okay, this is going to be a bigger event, maybe we can do this, and just make sure we have all supplies here. We have to make sure that we have enough participants. It's a lot for us to coordinate the logistics of doing these events, so we have to make sure we have enough participants at these events. Nothing more discouraging than going to an event and you only screen like one person or something like that. It's not really beneficial or anything like that. Another challenge is basically looking to convert a lot of the people who had uncontrolled numbers to have them come for care and stuff like that. It's not an automatic. A lot of them don't want to do it or they don't think anything is wrong. So that's a challenge. So we're still trying to work to raise that number of patients who did have uncontrolled blood pressure or high HbA1cs to come and see us and seek us for care. The other issue is once we're able to convince that patient to come in for care, they're actually a good percentage of our no-shows. Another challenge is, of course, you making sure that you have enough staff to basically be able to go and perform these events. The volatility of staffing is making sure that you have enough to not only do your events, but making sure that you have enough people in your practice to continue your in-clinic operations. Next slide, please. Status of the objective, basically for our looking to increase our number of established patients through community outreach events. We still have a number of community outreach events that are scheduled throughout the next 6 weeks to 2 months. So we are still looking to review and modify our workflow so we can still not only attain these events, but look to meet our goals. Next slide, please. My next presentation is just discussing the standardization of workflows with follow-up appointments with our African American male population. Next slide. For our African American male patients, we decided to take a little bit more of a proactive approach in standardizing a workflow to basically make them ahead of time when they're here, make a follow-up appointment immediately. African American males basically were the highest demographic that, we had, of course, the highest uncontrolled blood pressure. And what we noticed is that they did not come more frequently for their follow-up appointments. So what we decided to do from a historical and systemic factors do play a role in those numbers. They conclude basically social drivers of health, the conditions, and basically what they were born in, and the factors that they lack health care or they can't get off of work or whatever other barriers that may stop. Other things may include, not promoting food or health in their diet, or anything like that that could actually stop them from making sure that they are not following up on their care. So with historical trends and everything, we're just going to make sure that now that we have you in the office, we're going to set a follow-up appointment with you before you leave and discuss more in depth about goals and what's needed to lower your blood pressure. Next slide, please. In addition to those things, we also started to notice from a historical standpoint that a lot of younger African American males are starting to have uncontrolled blood pressures. So we're starting to be a little bit more proactive and get them involved in treatment plans and good practices early. So what we do for the follow-up protocol, we identify African American male patients that have diagnosed high hypertension. This also includes not only just brand new patients through their insurance carriers, but we're also looking to work with also patients who've had recent hospital visits so they can come in, do their follow-up here and look to establish care and have someplace steady where they can come and monitor their health care. The care team will schedule the follow-up appointment before the patient leaves. This could vary between 30 to 45 days, depending on how bad or how extensive was their blood pressure. This gives you time to make sure that the medication adherence works. This also gives an opportunity to promote a goal on what's needed to be set to be controlled blood pressure and promote SMBPs, make sure that that actually is promoted during the course of the visit. The goal is set between the patient and provider. We actually are starting to promote more of a patient engagement approach. So it's not like the provider is just coming in doing all the talking. This is more conversational based between the provider and the patient. And then we'll just keep the follow-ups going until your goals are met. Once the patient comes in a couple of times, I basically pull the data and basically share it with the team just to show that, the follow-up appointments are working. You can go to the next slide. So this is just an example of what the follow-up protocol has done for the program year. So as you can see through the first 3 quarters, what was considered controlled and what was considered uncontrolled. You can see where our numbers are. So you can tell by the first quarter, that's where we started. And then the second quarter really took off. And then we're kind of like mellowing down through the third quarter. From a historical standpoint, that's about right, because that's pretty much how our patient volumes are volatile and they go up and down and all that kind of stuff. So we're still shooting for at least above 70% for controlled blood pressures among our African American male patients. Next slide, please. Challenges in reference to making sure that we're helping this demographic, of course, high no-show rates among this demographic. We are trying to get better to make sure that we're sending reminders, texts, everything to remind them. We've even gone as far as making sure that if there is a caretaker, relative, spouse, wife, whomever, that they are aware and we have permission to speak to them in reference to remind them about their blood pressure appointments. There is still some distrust in the medical community. So even though that the provider may have set a goal and tried to engage the patient, if we notice that the patient isn't happy with that provider, it could be something as simple as, well, I may not feel comfortable discussing this with a female. I will consider with a male. We could switch the provider really quickly and have them talk to a male where they can relate to a little bit better and everything. We have seen some success with that early, with that in reference to getting advice and all that kind of stuff. Caretaker assistance, we ask if there's a spouse, daughter, son, anyone that's helping in your care, and we try to get them involved early so we can try to get controlled blood pressure rates and get them involved and let them know what's going on and all that kind of stuff and everything. It also sometimes becomes a family affair because a lot of people also learn what's considered healthy, what's considered good, and all that kind of stuff. Changes in attitudes and beliefs and dietary and lifestyles. We all know that sometimes it's very difficult to get men to change and eat healthier. There's certain things you might have to give up or cut down, low salt, more exercise, more water, changing other lifestyle habits, in order for them to get healthier. It's difficult. Sometimes that first conversation is very difficult. But sometimes if you just the provider keeps going and keeps insisting of the dietary change and lifestyle change, we actually see better results. Just keep repeating and keep going. The last one is just education from outside third party and internet. We are in the 21st century, and unfortunately in 2026, we get bombarded with a whole lot of negative press. You get these quote unquote so-called experts giving bad advice. I listen to my friend that lives around the corner. They do this, and I don't think I need to do that. So you run into that challenge with them and everything. So basically, you're at that advantage of trying to, or should I say, disadvantage of trying to communicate with the male patient in reference to what's real, what works, and what happens. And all we have to do is, since we're real grassroots, we just still keep reiterating what's real, what's good, what works, and what's needed. Next slide, please. Status of this objective for us to basically continue to improve our metric here. We will still continue the workflow and make it standard and common practice. We will continue from a QI perspective to review and modify if needed to make sure that we still try to reach that goal that was set in the work plan. As next steps at the end of the project year, we're going to basically share all the data with all the leadership and all the stakeholders, in addition to the EECH, and continue to build and expand from that. As I mentioned in one slide, that this is a marathon, not a sprint. We may not be able to reach the goal that we intend, or if we do, maybe we can raise that goal, that we can continue to keep grassroots and keep working hard to make sure that we improve those numbers. Again, we are a small center, but we have a big heart and a big mission. And that's what we like to do and help improve health outcomes within our community. Does anybody have any questions, comments?
Great presentation, Crystal. Thank you. This is Shannon. I wanted to know, in your community engagement, did you come across insurance as a barrier? And if so, what was the magnitude?
So it is a mixed bag, depending on the event. We have run into some issues where some patients do not have insurance. Those patients that don't have insurance, we do offer the sliding fee scale here at Elaine Ellis. The interesting thing that I did notice through the data, a lot of the people that had the uncontrolled blood pressures and stuff like that actually had medical insurance. It was just a situation that they just didn't either they didn't seek their primary as often as they should. Um, some are not religious and taking their medication adherence seriously. It was just a number of things. That was the one thing that I did notice that was very, very interesting in this data.
Mhm. So they were insured and had a primary care. They just weren't regularly engaging in care.
For some, yes.
Yeah, it's interesting. And then I saw that you mentioned no-show rates or no-shows as a barrier. Who on the care team, or yeah, it could be multiple folks, is sort of taking the lead on making sure folks show up to the appointment.
So that's a combination, like you said, of individuals. Let's say an example of I was a patient that I am a no-show, and the provider is reviewing the schedule at the end of the day and realize that person didn't show or I didn't show, and I have a history of high blood pressure or anything like that.
Mhm.
We are going back, and it depends. Some providers are going back to review, like, hey, what happened? That type of day, to call out the patient depending on the time of the day. If
Okay.
not, we will have the front desk basically go back to all the no-shows and recall and reschedule that appointment accordingly. So it's a combination.
Okay. Thank you.
Thank you so much, Crystal.
Thank you.
Okay, so just next steps again. Our next learning collaborative for Monday, you will receive an invite for that. I will send any like registration or passcode information as needed. I will also send a follow-up with this, what was covered today, some of the data products questions as well. If someone did not get a chance to fill out the surveys at the Slido, we can do that through via email. If you have any questions, please feel free to forward that to us. And the recording will be posted on the Living Well site. Before we wrap up, I'm just going to open up the quick evaluation poll for this learning collaborative, and we want to thank you all for your attendance today. So if you can all just fill out those post evaluation questions, and have a good rest of your day, everyone. Thank you so much.
Thank you.
Stop recording. Okay.